Hi, and welcome back to the Dr. Robbins YouTube headache channel. You can find more info on us at chicagoheadacheclinic.com. And this is a series of talks and interviews that we'll have about various topics in headache. Today we're talking the first part of 2 or 3 parts on psychiatric conditions that often go together with headache patients. A lot of headache patients do have anxiety or depression, and people would naturally think, well, sure, I have daily headaches or frequent headaches. Naturally, I'd be depressed or anxious. But they actually just go along their shared genetic comorbidities. These are genetic chemistries in the brain, whatever brain chemistry we inherit. And of course, pain that's not treated will fuel depression, and depression that's not treated will fuel pain. So we need to treat each separately. I'm going to focus today on personality disorders first, and then later on in other segments on the bipolar spectrum. Now, personality disorders are interesting. You study personality disorders, you realize that a lot of the bad things that happen in the world are because of leaders that have a personality disorder. And I always say the lack of recognition of personality disorders leads to major problems. The clinical stakes for not recognizing personality disorders and the bipolar spectrum are huge. So why do we look for personality disorders? They tend to be dangers to themselves and to their family. It's important to recognize. They tend to be dangers to doctors and nurses and clinics sometimes. They're very disruptive. Personality disorders can cause great havoc among medical staff and in hospitals. They drain a lot of energies. I think that if we look at the energies of a person as how many energy marbles do you have for the day? And where are we going to spend those energy marbles? We have to decide. Well, also emotional marbles. Where do we spend all of our emotions? And a clinic, say you have a headache clinic or a pain clinic or a neurology clinic or medical, what patients will you give all of your energies to? And if you have one person who's a severe borderline personality and they drain everybody's energies and they have none left over for our normal patients who have anxiety and depression and headaches, that's not good because everybody's burned out. A recent study indicated that almost 58% of headache doctors feel burned out. Now, once a doctor is burned out or a nurse is burned out, it's not good for them. It's particularly not good for the patient because they don't care as much. They don't really want to prescribe or think about medicine other than the easiest thing to do. They're just looking for a way out to get out of clinical medicine. So to avoid burnout, we need to limit personality disorders in any one practice or keep boundaries, and I'll talk about boundaries a little bit later. Now, the treatment differs for personality disorder versus bipolar. We don't, we try not to conflate the two, and in the popular media, personality disorder and bipolar are often mixed up. They'll say that Lindsay Lohan, for instance, is bipolar, but really she's more borderline. She has a lot of borderline features. Charlie Sheen, the same way. Now, they may also be bipolar. A lot of people with personality disorders fit into the bipolar spectrum or have other psychological comorbidities like ADD, but that's not the main problem. So what I want to do is talk a little bit about the characteristics of personality disorders, more about why we recognize them. Recognize them guides us towards being able to set limits and boundaries. We can't let certain people with personality disorders run over the clinic. For instance, say George is a paranoid personality disorder and he's angry all the time and he calls the clinic and he says, I want to talk to Dr. Robbins right now. And everybody gets really mad and says, okay, we'll put him right through. And then he barges in and we kowtow and we don't set limits and boundaries. Well, at some point, it all explodes and nothing good happens. So what we want to do from the beginning is set boundaries and limits. We take a dialectical approach, which is go with the flow. Instead of constantly hitting the person over the head, you're wrong, your view is wrong. Unless it's a crucial issue, we try to go with the flow and go along and not constantly confront the person with a personality disorder. Limiting caffeine is very important too, and I'll talk about that in other talks. So how many people have a personality disorder? Probably about 10 or 11 or 12% of the whole population. But a lot of patients have an avoidant personality where they're alone in their apartment, maybe with their cat, and they get more avoidant as time goes on often. So they just don't have many friends, or they're socially inhibited as a teenager, and then they might go to college for a year or two and often drop out and end up under-functioning as an adult. We have a lot of avoidant personalities still living at home with mom and dad in the basement, and they end up with various jobs. Either they're a video game blogger that's not paid, or they're not doing very much, and they often end up on disability. But I'm going to focus more on the more severe personality disorders: borderline, antisocial, paranoid, narcissistic. Borderline is the most common. In my studies, about 5% of patients with in a headache clinic have a moderate to severe personality disorder, about 5% of chronic migraine patients. And that tends to be into those categories: the borderline, narcissistic, paranoid, antisocial. In inpatient headache units, almost 25% of people have a personality disorder. And if you look at inpatient psychiatric units, it's a very high percentage of people with personality disorder. And even outpatient psychiatric clinics, an outpatient general clinic at a university may have 25, 30, 35% with a personality disorder. So now, why do people have a personality disorder? It's what we call biopsychosocial. Genetics is crucial, and we look at family history, not necessarily as genetic as ADD, ADHD, or anxiety, or even bipolar, but there is mental illness often in the family. An uncle had schizophrenia, an aunt had bipolar, or a brother or cousin was hospitalized or institutionalized. So there's something genetically. And then the first 15 years of life, of course, it's nature and nurture. So we're born with a genetic predisposition towards certain things, and a lot of times stress as a kid, emotional abuse, physical abuse, sexual abuse may push somebody into functioning as a personality disorder. So the genes become expressed. Separation from parent can matter. Separation issues. Of course, we always used to blame the mom for everything. Even in the 1800s, if somebody went into shock from blood loss, we blame the mom. Schizophrenia, we blame the mom. And it turns out that it's not the mom's fault once they figure out what really causes these illnesses. But separation, if somebody's taken away from parents and they have the right or wrong genetics, they may end up with a personality disorder. And neglect as a child is very important. Now, what separates somebody with some personality quirks? What is personality? When we're looking at personality disorder and personality, it's really our pervasive way of looking at the world and functioning from early on, at least from age 13, 15, 17 on. Most personality disorders, at age 5 or 7, you could see hints of it. Sometimes it doesn't come out till age 18 or 20 or 22, but usually by age 18. But we always have to be careful diagnosing. Personality disorder is not so easy to diagnose, and that's a problem. We have anxiety screeners, depression screeners, 10 questions, 20 questions. We have even MMPI and Milan's more complicated psychological tests that can tell personality somewhat. They can tell anxiety and depression. But it takes months often to diagnose somebody as a personality disorder unless they're very severe. And that sometimes we diagnose somebody in 5 minutes. But for more milder personality disorders, it can take quite a while. But we look at their pervasive functioning month to month, year to year. Under stress, people can look like a personality disorder. Say somebody's going through a severe divorce and they have a couple kids and they go off the deep end and they're hospitalized psychiatrically. They have what we might have called years ago a nervous breakdown or a mental breakdown. They may get diagnosed as a personality disorder because they look like it, but they may not be. If we look at their functioning for the last year, 2 years, 10 years, so we always want to be careful about diagnosing too quickly under stress. Now, normal personality can adapt. It's flexible. Personality disorders tend to be inflexible and much less resilient. If you look at resilience, there's a gene, the serotonin transporter gene. 2 long arms leads to resilience. 2 short arms of that gene leads to lack of resilience. And if you take 2 short arms and you give abuse as a kid or stress as a kid, you'll often end up with a personality disorder, somebody really underfunctioning with a lot of problems. If they have 2 long arms, that may be the kid who does very well. 17% of kids who are severely abused or moderate to severe abuse with neglect end up very well. They almost always have 2 long arms of the serotonin gene. So resilience has a genetic basis and construct also. So personality disorder, personality tends to be self-defeating and rigid, and they have a lack of resilience. Now the symptoms in general personality disorder overlap. So these are artificial, borderline, antisocial. Many of these symptoms overlap. Most patients have symptoms of a couple of them, 1 or 2, sometimes 3. But in general, the symptoms, lack of insight. People with personality disorder, unless it's mild, often don't understand themselves. They don't say, you know, this is my fault and I create chaos and drama. It's everybody else's fault. So their general feeling is if the world would just stop getting me angry and stop cutting me off in traffic, I wouldn't hit them with a tire iron and I wouldn't go crazy and I wouldn't go into road rage. But that doesn't work. So lack of insight is a problem. That leads to a poor response to psychotherapy. And in psychotherapy, we take a different approach, more that dialectical approach, go with the flow that I mentioned. So it's not so insight-oriented, cognitive, behavioral therapy. It's really more behavioral, not so cognitive, really what to do day to day to get their lives better and not create such chaos and drama. Chaos and drama follow people with borderline personality. And a lot of times they'll say innocently, I'm the victim of chaos and drama, but then with some insight later on, many will say, you know, I realized I was elected the drama queen of high school. I create it, and I bring on the drama. So they do create it. I always say if somebody with a borderline personality lands on Amtrak in a city, in 15 minutes, like a magnet, they find somebody and connect up because it's that personality. They have difficulty with attachments and trust. People often will attach to maybe one person, but they don't even trust their mom, who may be their only advocate, because what happens as time goes on in the 20s and early 30s, people with a personality disorder, borderline, tend to lose their friends and family. They've gone through drugs and police and stealing and spending their parents' money on credit cards, and everybody's sick of them. And they say, just either get better or leave us alone. So they end up isolated, which makes the problem worse. Then they end up suicidal. There's a sense of entitlement and an arrogance to many with a personality disorder, or I call it PD for short. And that sense of entitlement, think of the person who comes into a restaurant and has their head up, and I only want to sit here, and is screaming at the waitress, and everybody's afraid, and the maitre d's afraid. Or they come into an office or at a grocery store, and they're giving all the workers a hard time. They see everybody beneath them as almost subhuman and treat people terribly. So if you see that, we think personality disorder. They do create drama and chaos and stress. and feed off of it. So getting legally involved in somebody with a personality disorder always often doesn't work. They like the enmeshment. So people think, and this is a common situation, say you take a condo situation where one of the persons has a personality disorder and is suing over nothing or creating drama and chaos for no reason. People think, well, we'll get a lawyer and we'll countersue and we'll sue them and they'll get afraid and go away. They don't. They love the enmeshment. So we treat people with a personality disorder different and react differently. Now, anger and agitation are common in people with borderline and antisocial particularly. Poor relationships, they often end up, as I mentioned, isolated. They can do well over time. People with personality disorder can do well from age 30 to 50 if they're not so isolated, if they have some family support, and particularly if they're working. Suicidality with borderline personality untreated, if they're not seeing a therapist and they get into their 30s and they're isolated, suicide's a huge risk. Self-injury. And self-injury merges into suicide. Sometimes they didn't set out in the car to absolutely kill themselves, but they're driving really fast, 80 miles an hour in a 40 speed zone. They're a little high on whatever they got, and they don't really care if they hit the concrete embankment. They're not trying to kill themselves, so it's in that gray zone. Mood swings are very common, and instability with mood. You can be up one minute and down the next, and that can merge. People confuse that with bipolar. Even rapid cycling bipolar tends to have weeks or months of one phase. They'll either be hypomanic-y, a little bit too high, or more likely depressed with bipolar. As we'll mention in other segments of this talk, with bipolar, 90% of the time it's depression is the problem. But with borderline personality, it tends to be up 1 hour, down the next. So they can be a little high or normal, and then you're walking on eggshells 2 hours later and afraid to say anything because they're irritable and they're mad, and any little slight they will get angry with. They're very thin-skinned. Substance abuse is very common. A lot of people with personality disorders will self-medicate, and it's not the main problem, but you need to treat that. If we don't treat substance abuse, nothing gets better. And impulsivity and recklessness. Impulsivity is a key construct in predicting how somebody's going to do in their 20s. If they're very impulsive as a teenager, they jump into the car with somebody going to do drugs, they will go to a fight or say, oh, there's a gang fight going on. This sounds like fun. I'll go there. Impulsivity and spending. This is a problem with borderlines, but if they're getting better at age 18, 20, 22, that's a good sign. If they're 22 and 24 and the parent said, you know, my son Johnny is just no better at all, it's not a good sign. So we look for impulsivity. Is it getting better? Spending, it's different than manic bipolar spending. If you look at the closets of people who are borderline or actors, actresses who are borderline, often they'll travel with an entourage of their shoes and their clothes. They'll have a whole separate hotel room with closets full of their clothes and shoes. If you go into the room, the apartment of somebody who's borderline, often they have unopened boxes from eBay and Amazon all over the place. And if they get a hold of their parents' credit card or some friend's credit card, they'll max it out. We've had situations where they put their parents $300,000 in debt ordering off of Amazon and not even opening the boxes. That's the constant spending to fill themselves up. They have a hole. A lot of people with borderline particularly have this malignant, horrible loneliness. And if I ask them, do you feel lonely? Are you really lonely? The answer often is yes, chronically. And they fill it up with spending or drugs or men or women relationships. They always have to fill that unending hole up. And it's a horrible way to feel. I feel very badly for people with this. It's not easy to get through life. Emotional lability. Now, a little more on the spending. Manic spending. If somebody gets into a manic phase of bipolar, their spending tends to be a huge amount, but over days or a day. They'll spend $10,000 or $20,000, wherever they can. They'll buy a boat. They'll buy a car impulsively. And they'll be in a manic phase. So they'll be talking really fast. and they might not be sleeping, and their mind is spinning. It's not the chronic day-to-day spending of the borderline. Emotional ability, up and down, as I mentioned, is a key. Lack of resilience. Aggressive behavior. A lot of people with borderline and antisocial tend to be very aggressive, so they can ruin offices if they're the office manager. For some reason, and I have some ideas why, people with borderline, antisocial, particularly borderline and narcissistic personality disorders, tend to rise in organizations to mid-level management or CEO. And there's some famous CEOs, the one of Tycho Kozlowski, who went to jail, and they rise there, and then they tend to ruin an organization. They can be very good salespeople, and the flip side of borderline often is a very charming person. They suck people in. They have a charming sales quality to them, and sometimes very seductive. So they will attract the opposite sex, and then it all falls apart after marriage. So the problems that lead in organizations, and I've talked to some HR departments about doing more screening for personality disorder, because everybody underneath the personality disorder is a nightmare. They have problems interpersonally, fear of abandonment, which I mentioned, and lastly, and then we'll talk in other segments about a lot more of these issues and go into each personality disorder, there's poor self-esteem. Often identity issues. People with borderline don't know who they are, so they take the identity of somebody they're with and glom onto them, or constantly searching. So poor or low self-esteem is almost a hallmark. So in the next segment, we'll go into each individual personality disorder and then talk about bipolar. Thank you.